No one can deny that Covid-19 has changed us, but it's also exacerbated something that already existed. There are deep divisions in our society, and Covid has really shown up those cracks. There's lots we're still learning about the virus. Much is still uncertain, but one thing is crystal clear. Ours is a deeply unequal society, and that fact was never going to help us come out of this well. The data on that are clear. Dr. Mehrunisha Suleman is leading an inquiry examining how Covid has impacted health and health inequalities.
What we saw from this evidence was that this burden of ill health was unequal, and those from more deprived communities had a lower level of healthy life expectancy. An example of this is that women in the most deprived parts of the UK have a healthy life expectancy almost 18 years lower than those of women in the more wealthier parts of the country.
This graph shows how, compared to the wealthiest 10% of the population, the poorest 10% have been more than twice as likely to die of Covid. The wealthier you were, the less likely you were to die. But existing ill health is only part of this story. There's a double whammy. Those groups in the poorest health are also those most exposed to Covid.
Having pre-existing illness is a factor, but not the whole picture. Being more exposed to the virus means that you're at greater risk of succumbing to the virus. The factors that play into exposure is about the type of work that you do. We know that there's a high risk of exposure and worse outcomes amongst key workers, those having to interact with people. It's important to note that employment had been rising prior to the pandemic, but what we see is a decline in quality of work, and also that incomes stagnated prior to the pandemic, and the impact of that has been unequal.
It's not often you get a near perfect correlation in a graph, but look at this. This dot represents the UK's least deprived area. It shows that around 48% of residents living there can work from home. As we move gradually from our least deprived areas to our most deprived areas, we see the percentage who can work from home falling. Under a quarter can in our most deprived areas. The correlation is clear. So those groups who are the least well off have been most exposed to the virus. The risk has been transferred onto them, and many of these people are from ethnic minority backgrounds.
When we're talking about structural racism, within that we're thinking of things like unequal work opportunities, which mean that ethnic minorities are often more likely to work in high-risk jobs, such as working in factories or working in healthcare, where they're more likely to come into contact with members of the public, or in working in closed spaces, in jobs they can't do at home, but also having different access to high quality housing.
2% of white British homes are officially classified as overcrowded. We can see that for households from an ethnic minority background, the figures are far higher, reaching 24% for those of Bangladeshi ethnicity. Professor Rob Aldridge has exclusively examined the effect of this in the pandemic for Newsnight.
We've known for a long time that respiratory infections like tuberculosis are associated with an increased risk of infection for people living in overcrowded households. The UCL Virus Watch study has been following people up since June 2020, and we asked our participants about their household circumstances, how many rooms they have, and how many people are living in their households. And when we looked at those households that were overcrowded, we found that they had twice the risk of coronavirus infection compared to people living in undercrowded households.
People will be unpicking for years to come why countries fared differently from one another in the pandemic. It's likely to be a really complex mix of issues, but something people are clear on is the role of inequality.
I think more and more people are recognising that the pandemic has hit different groups differently. We know that an equal society is a less resilient one. And so that's something that will be crucial for us to think about going forwards.
It will likely take some serious untangling before we fully understand why so many have died, but we knew there were already deep cracks. We now know they were deadly too.
Deb Cohen, well, we did ask a member of the government to join us this evening and they declined. Joining me now is the Shadow Health Secretary, Labour's Jonathan Ashworth, Conservative Gavin Barwell, who served as the former Prime Minister Theresa May's Chief of Staff between 2017 and 19, the Chair of the Council, the British Medical Association, Dr. Chaan Nagpaul, Dr. Shola Mos-Shogbamimu, author of This Is Why I Resist, and Hilary Cottam, a social entrepreneur and author of Radical Help, How We Can Revolutionise the Welfare State. Good evening to you all and thank you for joining us. I'm going to come on to inequalities, overcrowding and other issues like that in a moment. But Dr. Nagpaul, I want to begin straight away with the NHS. I mean, the NHS stepped up. We heard from the nurse there, Becky, that they were firefighting all the time. Why was the NHS so unprepared for this pandemic?
The trouble is we started the pandemic in a deficit. We have about a third of the hospital beds of France and Germany. Our critical care capacity was a quarter, for example, of Germany's. We had about 100,000 vacancies in the NHS, 10,000 jobs for doctors not filled. So we started in an impoverished situation. And then when coronavirus hit our shores, we had to basically stop our normal NHS services to create space. We had to repurpose doctors and nurses to provide critical and urgent care for coronavirus patients. And over the first wave, there were about 12 million fewer patients seen for non-COVID problems. And in fact, during that time, the other toll that was taken was 12,000 excess deaths from patients without COVID, which hasn't been publicised, but they lost their lives because the NHS really was effectively a national COVID service. We had to be, because we didn't have the facilities and the capacity to do both.
But how,
and the other issue that...
Sorry, Dr. Nagpaul, I want to ask, had you, say, as a profession, been sending out alerts to the government about, for example, particularly on the lack of ICU capacity in the NHS in the UK?
I can tell you that we have been repeatedly warning the government that the NHS has been precariously short of facilities for critical care, hospital beds, community facilities, and we've been raising that for years now. And of course, when this pandemic hit us, we saw the problems of not having that capacity. And in addition, we didn't have the PPE either. So we were pretty impoverished on all fronts in trying to cope with this sudden surge of infections. Yeah. And we didn't have the capacity.
So, John Ashworth, just thinking more broadly about attitudes towards crises, this goes back a long way in terms of pandemic preparedness for a crisis like this. And even back, Tony Blair talked about it in 2005 when he thought he had the bird flu crisis on his hand. And I think that the phrase was, I tried to do the minimum I could with the minimum expenditure. It's never been a priority for any government, it seems, to do pandemic preparedness.
There's been complacency. And actually, when you listen to the experts, they've been warning us now for some years that we're in an era of pandemics. We've seen more small epidemics emerge across the world. We've seen Ebola in West Africa, Zika in South America. We've had a number of pandemics, I think 6 pandemics since the Spanish flu outbreak 100 years ago or so, including a SARS and a MERS pandemic. And yet the world sort of moves on so quickly and forgets about it. And I think that has been one of our weaknesses. We've had a sort of complacency at the top, poor decision making, and not following the science. And I don't think we can ever do this again, because climate change, and particularly the destruction of biodiversity across the world, means that more viruses will jump from animals to humans. Sadly, and I don't want to be the depressing voice here, we are likely to see more pandemics. So pandemic preparedness and response has to become a national priority.
Gavin Barwell, is that something you agree with, that we haven't had the preparedness, we haven't given it enough serious consideration?
I think the risk register the government ran had a pandemic as one of the most serious risks that was being prepared for. But I think we were preparing for another flu pandemic, not a novel respiratory virus. I think the points that have been made about the NHS need more funding are fair ones. You know, when Theresa was Prime Minister, she tried to recognise that with the long-term plan to put some additional funding in. But I also think we clearly made mistakes at the start of the pandemic in what was an unprecedented situation, being too slow to put restrictions in place. And that's what led to, there were already a very large number of people infected at the point we went into lockdown, which is what led to the NHS essentially being overrun with the number of COVID cases.
And we are going to come on and talk about the difference between what happened in March and the autumn in a little while. But Dr. Shola, do you have some sympathy with the government over that lack of preparedness? Or as Gavin Barwell says, planning for a flu when actually it was a novel respiratory virus? Do you have any sympathy with the government's predicament?
Absolutely not. No sympathy whatsoever. Let's be clear, and let's not suffer from any selective amnesia here. The biggest threat to this country's ability to manage coronavirus pandemic was the British government's utter incompetence in mismanaging it, the ineptitude, the failure to learn from lessons from other countries that were ahead of us, who were clearly experiencing the devastation. The fact that we failed to put restrictions in place. I don't question the fact that it was unprecedented. That's not the point. The point is there were actions we should have taken, we failed to, and there were clear omissions. We had a prime minister who at the beginning, and I'm not talking about January now, who was very clear in saying things like he's shaking hands with people with COVID. We have a government who actually fed misinformation and actually continued to use very not clear, strong language to give guidance to the people. That caused the problem. What it did was to feed the distrust that the public had, and what it did was to feed the disinformation, especially for people who did not believe COVID-19 was a problem. So without a doubt for me, if coronavirus pandemic was World War II, Boris Johnson was not Winston Churchill.
Let me turn now to Hilary Cottam. Let's go back to Pendle. And let's also go back to what Deb Cohen showed in her graph, that there is a clear correlation between inequalities, overcrowding, people having to go out to poorly paid jobs, not being able to stay at home, and the virus. Could that have been tracked much earlier, more clearly, about the impact? Because poor health, people with multiple economic issues have poor health outcomes. It was obvious, was it not, that they were going to be hit hardest?
Absolutely. I mean, we've heard really moving stories this evening about pressure on the front line, the stories Pendle in the community. But the thing is, these troubles aren't new, and our systems were already unravelling and have been for some decades. So what we're looking at now is the effect of this deep structural challenge, which is sort of threefold. First of all, we've created jobs in this country that pay so little that people can't afford to feed their families. They're vulnerable. They're living in very poor housing. We know that families can't afford basic things like internet, so they haven't been able to learn. These are things that have been going on. They're in the communities I work in. We've been talking about for a long time. And then what we've tried to do is we've tried to kind of stick the band-aid of the welfare state over it and kind of tinkered with the welfare state to try and kind of address these deep sort of structural fissures and inequality.
But let me ask you, do you think policymakers, and I'm not just talking about policymakers who are Conservative or Labour, do you think policymakers are, by and large, often out of touch with people's lives?
Absolutely. I mean, there's been a complete lack of realisation of what's going on, which we've heard, you know, well, we've seen Marcus Rashford have to point out that people can't eat. We've had kind of endless discussions about what's happening in schools with absolutely, I mean, I work in Barrow, for example, where school teachers every day have to photocopy sheets and they drop them through pupils' doors because there's no data packages in those homes, there's no space to learn. There are all these things. But also it's a kind of mindset, which is that we've got these, you know, transactional policy making ways. We've got sort of politicians that operate in these very kind of top-down ways, command and control. We saw the failure of that in test and trace, but we've seen the failure in kind of policy making.
Well, let me put that to Gavin Barwell first of all. Has there been a position, and I'm going to put this to John Ashworth, about command and control? Actually, you know, people do not, when they go into politics, actually often go out and see what's happening on the streets everywhere in everyday life.
Well, first of all, I think it's not important not to generalise about politicians. Lots of people on both sides that go into politics have been local councillors, have started as community campaigners. Secondly, it's too simplistic to say top down is always bad. You know, if you think of the vaccine rollout programme, the contracting and the orders of the vaccine, that's important for the government to do.
Yes, and that's right.
Policy making is to work out what do you need to do nationally and where do you need real local intelligence from the coalface about what's going on. And the government hasn't always got that right, but you can't generalise and say that it's never right.
Tell me, you know, if, as you say, we went into lockdown too late in March, what happened in autumn? Because we'd had actually a very clear indication of what was going to happen. Did we do the wrong thing in the autumn, and was that a failure of leadership?
Yes, definitely. So I think there were mistakes made in March, but actually in that unprecedented situation, I think it's more understandable. And in particular, we didn't have enough testing initially, so the data that the government was getting wasn't great in March. But in September, there was clear advice to the government that it should order a circuit breaker lockdown. It didn't do that. That was clearly a mistake. Now, there are, you know, I think any honest evaluation of what's happened over the last year, the government has got some things wrong and it's got some other things very right. And I hope when we have the inquiry, we can have a proper, grown-up, non-political discussion about what the mistakes were and what the successes were.
And I think, John Ashworth, the problem, though, with an inquiry, of course, is it's kind of after the fact. And we've had so many deaths in this country. Our death rate is one of the highest in the world. Do you think... Sorry, what were you saying?
I was going to say, yes, I mean, we need an inquiry, but it needs to report before a general election. But I think what angers me, I mean, there's a debate about when the lockdown restrictions should have come in. I believe that Boris Johnson was too slow on all three occasions, and that is unforgivable. But what is more fundamental for me is that we know that this virus cruelly exploits inequalities. Those with long-term conditions, whether that's diabetes or hypertension, blood pressure, COPD, they are more vulnerable, and those conditions tend to cluster in poorer areas. But it's also poorer people who don't have the luxury of sitting at home all day long on a laptop joining Zoom calls, who have to go to work, even in a lockdown. They have to get on public transport, perhaps, or they live in overcrowded housing. So it should be no surprise that we see higher death rates in poorer areas, that manual workers, security guards, taxi drivers, and so on are the professions where you're more likely to catch the virus and sadly die from the virus.
We'll stay with us now.
And they're not giving people sick pay to isolate when they are ill. I mean, these are the fundamentals that need to be fixed.
Well,